Hi friends, welcome to today's session. Today we'll be talking about the AIIMS questions which were asked in November 2019 session. Hi friends, welcome to today's session. Okay, so I'll just wait for a couple of minutes. I'm really sorry for a delay of a couple of minutes because of some tech issue. And right, so let us start. I hope you guys are there, and yeah, let us start without wasting any further time. So if you want to have any, do you want to ask me anything, you can definitely put it up on the comments and I'll definitely tell you. So the AIIMS this year had a pretty good amount of surgery questions. They were around 15 to 18. I have been able to recall 15 accurately. So let us have a discussion about 15 questions which were asked in your AIIMS 2019. Right, so the first question was identify the instrument shown in the image. So this was a pretty simple question, and the answer to this particular question is no doubt monopolar Quadtree. So it was a very simple question. So this is a monopolar Quadtree, and I hope every one of you have got this right. Now we'll just take up time to discuss in bit about the Quadtree. So in image 1, what you're seeing is the surgeon is performing a operation, and what he is having in hand, it's a a type of a bipolar Quadtree. Now, why is it a bipolar Quadtree? Because here the circuit is getting completed in the Quadtree itself. So what is the basic difference between a monopolar Quadtree and a bipolar Quadtree? In a monopolar Quadtree, what happens? The surgeon has just this tip. So this tip which the surgeon has, this tip is applied towards the body, but the current needs to get completed, right? So how is it getting completed? So the current is passing through the body of the patient, and on the patient what we have a patient plate, and through this patient plate the current again goes back to the instrument. Now this is how it is completed. Now what I'm showing you here, this is a patient plate. Okay, so this is a patient plate, and where do you use it? You use it in a monopolar Quadtree. So as you can see, this is a adhesive, and this is applied or stuck to the skin of the patient like this. Okay, now why is it done? So that the circuit is getting completed. Now let us have a look at the advantages and disadvantages of using a monopolar Quadtree. So it is easy to use, that is fine. It has the advantage of using a both cutting as well as coagulation current. So guys, please understand one thing. What we have, this is an instrument. Okay, so what are we having over here? This is an instrument, but what we will be doing with this is passing the current through it, right? So we will be passing the current through it, and that is what is called as we will be passing monopolar or a bipolar current through it. I'm really sorry, just a minute. Right, so we will be passing monopolar and bipolar uh, we will be passing current through it, right? So this is just a Quadtree system. So we'll talk about that again. So it is easy to use, and what are the types of the current we have? So we can either pass a cutting current or a coagulation current. That is the main thing. Now what happens is dissecting capability. So in monopolar Quadtree, what we have a dissecting capability. It means that we can dissect through the tissue. So during surgery, we dissect the planes. So we can use the monopolar Quadtree to dissect the planes. That is the basic advantage of that. What is the disadvantage? This is largely the large volume of the tissue is injured, that is fine, interferes with the electric implant. So if the patient has, a pacemaker or any other electric implanted in the body, it might interfere with the signals of that. And another thing is it requires the ground pad. What do you mean by ground pad? The patient pad. So this is about the monopolar Quadtree. What is this? Again, a very, very simple thing. This is a bipolar Quadtree instrument. So what is this? This is a bipolar Quadtree. Right, now let us have a look at the advantages and disadvantages of this. So in this, what is having, we have the small volume of the tissue is injured, that is fine, and there's a less risk of the burns. So what about this? How can burns occur in a monopolar Quadtree? Now just understand this. We are applying this patient plate over the body of the patient. If due to some reason this patient plate is detached from the body of the patient, what will happen? Let's assume this is the leg of the patient, and we are applying a patient plate over like this. Now due to some reason, if this get detached from the body of the patient and it lies straight, Okay, and what we have, this is the limb of the patient. So earlier the current which was passing from the body into the patient plate with this surface area, now it has only this surface area in contact. So the concentrated current will pass, and while passing through the body, burns can occur over here. So this is one type of Quadtree burns. What do you call it? Quadtree burns. So this is what they mean. In bipolar Quadtree, because we don't need a patient plate, so chances of burns are less. It is safe to use in the electrical implant, that is fine, and effective even in the wet field. Disadvantages, more skill is required, that is fine, nothing great about it. Here we can use only the coagulation current, we cannot use a cutting current, and it doesn't have any dissecting capability. So this is important thing. Now, this table is absolutely very important for you. Now, what we just saw, those were the instruments like the monopolar and the bipolar Quadtree. What is this? This is a cutting current which can pass through and coagulation current which we can pass through. So what is the characteristics of these currents? So cutting current is a low voltage and a high frequency current. On the other hand, coagulation current is a high voltage but a low frequency current. So this is something which you should remember. Cutting is low voltage, high frequency, and coagulation is high voltage, low frequency. Another thing is, this is again, you should remember the lateral spread. So it has, cutting current has a less lateral spread and coagulation current has a more lateral spread. So that is why the chances of injury to the surrounding structures when we use a coagulation current, it is comparatively higher because the lateral spread of the current is more with the coagulation thing. Okay, do you understand this? This is a very important table you should remember. And what is this blend? So whenever if you look at the Quadtree machine in detail, so you will have a cutting. So this is one extreme and you have a coagulation, that is the other extreme. And blend is, we have blend 1, we have blend 2, we have blend 3. So what is this? This is a combination of settings in which we get the advantages of both cutting as well as a coagulation current. So blend is something in between the cutting and the coagulation. Okay, are you understanding? So this is a low voltage, over a period of time it will become high voltage. This is high frequency, over a period of time it will become low frequency. Here there will be mid voltage and mid frequency. Okay, so this is something which you should remember. Moving on to the next question, again a very simple question. Patient presented to you with a bed sore, identify the grade of the bed sore. So what is the grade of this bed sore? This is grade 4 because you can see the underlying bones. Now let us have a talk about bed sores. Now when do bed sores occur? Bed sores occur if the pressure rises above this capillary closing pressure. So can you tell me what is the capillary closing pressure? The capillary closing pressure is around 30 mm of Hg. Now what happens when you sit, for example, you must be sitting in the classes or anywhere, so you constantly keep on changing your position. But if at all due to some reason the patient is not able to change his own position, for example, if the patient is quadriplegic, patient has suffered from a pelvic fracture and the surgery following that, so patient is not able to change his position. So over a period of time what happens, because of the prolonged stay of the patient in the same position, the pressure in the interstitium increases, and if the pressure increases to more than capillary closing pressure, the blood supply to the skin, which is via the capillaries, it is reduced and there occurs a ischemic injury to the skin, and then the bed sore development starts. Okay, if it is not corrected, it will grow and develop into a higher grade bed sore, as has happened in this particular patient. Now another thing is, which is the most common site of bed sore? So what is the most common site of the bed sore? Please understand, it is ischium. Okay, so it is ischium. Right, so this is important. Right, then let us have a look at the staging of the bed sore. So how can a staging of a bed sore so this is something which you need to remember. Now what they do is, they usually, if at all they give it in the description, if at all they give it in the description, what they give is they can give this particular thing: partial thickness skin loss involving the epidermis and the dermis. So partial thickness skin loss. So if at all you don't remember this, you might confuse it with like partial thickness, it must be stage 1. But understand what is happening in the stage 1. There is just a non-blanching erythema. Okay, so it is, first thing is, it is a non-blanching erythema, and another thing is, there is without a breach in the epidermis. In other words, there is no breach in the epidermis, there is just the erythema which has formed, and this is also a non-blanching erythema. Now this is something which is different from the stage 1 burns or the superficial burns. Why? Because in that there is a blanchable erythema. Here there is a non-blanchable erythema. Okay, so this is difference. Then in the stage 2, as I told you, partial thickness loss involving the epidermis and the dermis, and the stage 3, what is happening? There is a full thickness loss of the skin extending into the subcutaneous tissue, but not enough to underlying fascia. So fascia is not involved, just the subcutaneous tissue is involved. And in stage 1, you will read the fascia as well as you may reach the bones and all those things. Okay, so rest is okay. Just remember the stage 2. Stage 2 is the partial thickness loss, and the stage 1 non-branchable edema without any breach in the epidermis. Okay, so this is important. Now the third question which was asked to you, what intervention has been showed in the following image? So what is this? This is basically a vacuum assisted closure. So see, 2 questions were asked on the bed sore only. So this is also one of the treatment of the bed sore. So how do you treat a bed sore? If at all you have this particular bed sore, how will you treat it? You will take the patient to the operating theatre. You will kind of okay, so in this particular, as the bone is exposed, you will have to rule out underlying osteomyelitis and everything. But let's see if at all there is a very bad wound, okay, with a slough and all those things. What you will go for? You will debride the wound properly, and then you may go for a vacuum assisted closure. Okay, so this is a vacuum assisted closure. I'll tell you how you do it. For example, if you see, there are various methods of doing a vacuum assisted closure. So what is happening over here? This is a cavity inside it, and the surgeon wants to go for a vacuum assisted closure of the deeper cavity. What he's doing, he's cutting the foam like this, putting the foam there, and then applying the foam over above. Above this foam, what is being applied is an adhesive, and you can see these tubes coming out. So these tubes will be connected to the vacuum. Okay, so these tubes will be connected to the vacuum, and that vacuum will generate a negative pressure. So important MCQ is, what pressure is generated by this vacuum? It is minus 125 mm of Hg. So please remember this. So this is how you can we actually do the vacuum assisted dressing in the OT. There are also the dressings which are available, which are pre-made. We just have to stick it, but yes, we can also make our own. This is fine. Then, so this is about the vacuum assisted closure. Now understand one thing, how will the vacuum assisted closure help? Now you all know one of the things, that if at all there is a local purulent discharge present at the wound site, will it be good? No, right? It will hamper the wound healing process. So that is why you apply this vacuum assisted closure. So what happens is, when the vacuum is generated, it will suck the purulent discharge is being let out of the wound over a period of time. So it will suck that purulent discharge. So what will happen? It will go away. So the local environment will maintain, and it will fasten the process of healing. Another thing is, it promotes granulation tissue. So there are various methods by which we can like the wound gets helped by the vacuum assisted dressing. One of the major things is, it sucks whatever the purulent discharge is happening, right? Now another thing is, where you will not go for this vacuum assisted closure. If at all the patient is having active osteomyelitis, or maybe the patient is having malignancy, then this vacuum assisted closure is not advised. Okay, so this is about it. Then next, they had showed you an instrument of the image, and they had asked where it is used for. So this was a simple Verey's needle, and you use it to create a pneumoperitoneum. What kind of pneumoperitoneum? So what is pneumoperitoneum? It is basically gas inside the abdominal cavity. Now what happens whenever, if you are an intern and you would have got scrubbed into some surgery, the only role you have is get a retractor and retract the abdomen. Now if you want to perform a laparoscopic surgery, who will retract the abdomen? You cannot put your hand inside, obviously, right? So you use air to retract the abdomen. This is the main reason, to create a room inside the abdomen. And for that, you have to create a pneumoperitoneum. You have to put the air inside the peritoneum. How you can put it? There are 2 ways of putting it. One, you can either approach by the closed method, which is by the use of the Verey's needle, but this is a blind technique. Please understand, it is a blind technique. So what happens here is, let's say if this is the umbilicus of the patient, and this is, the abdomen of the patient. So one surgeon and the other surgeon, so basically the abdomen is lifted up as a pinch over here, and then you take this Verey's needle and you go just below the umbilicus and you enter the peritoneum. After entering the peritoneum, you have to confirm whether you have entered into the peritoneum or not. How do you do it? There are various tests for this. So you have an aspiration test, and then you have a drop test. So you have to aspirate, you have to inject the normal saline, you have to again aspirate it, and then you have to perform a drop test, and then you confirm that you are inside the peritoneal cavity. This is about the closed method. But if you don't want to use this, you can also use a open method. For this, what do you have? You have this. What is this? This is Hudson's cannula. So this is Hudson's, it is called as a Hudson's technique. So what you do in this is the open method. You put in a below the umbilicus, you put in an incision, you dissect your way through the sheath, you cut the sheath, you see the peritoneal cavity, you catch hold of the peritoneum folds and you cut the peritoneum, and you can just put your finger inside it and you can see and you can confirm that you are inside the peritoneal cavity. Then you put this cannula inside and then you remove the stellate and then you can put your camera inside it. So this is how you go for an open technique pneumoperitoneum. This is important. Then what is this? Because they have been asking you varies needle and all sorts of needle over a period of time. So I want you to ask this. Have you ever seen this? Have you ever seen this, guys? So whoever is online, try to answer. Have you ever seen this? So this is basically called as a mochi needle. So what is this? This is a mochi needle. Why it is used for? This is used for closure of the port site. So let's assume this is the abdomen of the patient. So this is the port site which from where you have put in. So what you do is, this is a mochi needle. This is having the U like this. Okay, so just try to draw it. No, it's not not in the aneurysm. It is used for the closure of the port site. After the laparoscopic surgery, you create a port, right? So you put in your ports, like you can either put a metallic or a plastic port, but you put in a port. So after you take out the port, you have to close. If at all the port size was more than 5 millimeters, you have to close it. How do you close it? You close it, you may close it with the help of this. How you do it, I'll just explain to you. Maybe you have never seen this, so it will be a bit difficult. Now in the end, what you see, this has an opening like this. Okay, so you can pass a thread through this. So it is like a U-shaped needle. You can pass it through one end and then you can take it through the other end. So you have two sheaths like this. Just imagine this is a port which is between over here. So you pass one end of this U-shaped needle from this side. It goes into the peritoneal cavity and it comes through this side. So the suture which you have passed at the tip of it, it enters from here and it comes like through. So you can tie a knot and you can close the port. I hope you understand this. Okay, so this is just a mochi needle which is used to close the port in the after the laparoscopic surgery. Not yet asked, but because they have been asking these varies needle and all since a long period of time, they may ask you this, right? Then what is this? This is a Silverman's liver biopsy needle. Okay, so just remember, if you get a needle, whatever, thing like this, two prongs at the end, this is basically a Silverman's liver biopsy needle. This was also one of the options, so I just thought of showing you the pic. This is Silverman's liver biopsy needle, not very commonly used nowadays, right? Then a very simple question again, ABCDE principle is used for which malignancy? The answer to this is malignant melanoma. Okay, very nice. So nothing great about it. So what is A? A stands for asymmetry. Then okay, so one side is different from the other. Then B stands for border is irregular and notched or blurred. So border, B is for the border. Any irregularity or the notching or the blurring of the border, it is a sign of malignancy. It may indicate malignancy. The color of the mole is mixed. Diameter, if it is more than 6 millimeters, and E means there is an evolution of mole over time. So it is constantly changing over a period of time. So this is basically ABCD principle for the melanoma. That is completely fine, not great. Something which you should remember, you must have read it many times, but I thought it's a good idea to revise it because we tend to forget it. So in C2, if at all there is a melanoma in C2, what is the margin of resection? Only 0.5 centimeters. If the size is less than 1 millimeter, the margin of resection is 1 centimeters. If the size is between 1 to 2 millimeters, the margin of resection is 1 to 2 centimeters. Between 2 to 4 millimeters, you go for 2 centimeter margin, and more than 4 millimeters, again you go for a 2 centimeter margin. So this is an area which they keep on asking questions. So please have a look at this. Less than 1 millimeters, only 1 centimeters. 1 to 2 millimeters, it is 1 to 2 centimeters, depending on the size or whatever and the surgeon preference. More than 2 or more than 4, whatever it is, after 2, it is always 2 centimeter margin. So this is important, right? Right. So let us talk about the next question. Which IV line is preferred in patients with severe dehydration? So what is the answer to this particular question? It is gray. Okay, so gray, that is 16 gauge. See, understand, many of you have a doubt, why not green? See, ATLS says green. Previous ATLS said that even in trauma patients you have to go for a gray. But nowadays the newer ATLS is saying for the trauma patients you may go for the green. But for the dehydration, it is still gray itself. Okay, so over a period of time, earlier for the trauma it was gray, now it is green, but here for the severe dehydration you should go for a gray. Okay, that is the ideal preferred. Okay, so this is the answer for this should be gray. Okay, right. So IV cannula, size and color, you should remember this. So in the NEET, they might not ask you that. They will just give you the IV cannula and they will say what size it is, and they will ask you what is the gauge it is, and they may ask you the flow rate as well. Just need to remember the flow rate for orange, gray, and sorry, not the orange. You just need to remember the flow rate for gray, green, and maybe the pink. Okay, so let us have a look at this. So if at all, so orange is fine. If you remember, that's fine. If you don't remember, that is completely fine. Gray, it is 16 gauge. For the green, it is 18 gauge needle, and pink is 20 gauge, blue is 22 gauge, yellow is 24 gauge. What is the flow rate? For the gray, it is 180 ml per minute. For the green, it is 90 ml per minute, and for the pink, it is 60 ml per minute. At least this you should remember. Okay, so these three you should remember, and yeah, you must have gone through this so many times. I'm just trying to put it again on the slide so that you can revise. Okay, right. Another thing is, what is the French? So I'll just tell you about 2 points of the French. So this is a see, there is no kind of mnemonic for this, but it's not that difficult actually. See, understand, just remember these: green, pink, blue, and yellow. These are the ones which we most commonly use in the wards. So yellow is for the pediatric population, blue you may use in a very lean, thin females, or maybe in the childhood or something like that. Pink is something which we use routinely, and green when you have to go for a massive transfusion or a lot of fluids to be given or something like that. So I will suggest you that rather than remembering a mnemonic for this, you should actually try to remember the colors only. Okay, that will be easier rather than remembering the mnemonic for this. Okay, so yes, just remember in the sequence and then you can figure it out. Okay, so 180, 90, 60, that's fine, all going together, right? So Danish has already answered. What is the French? So French is basically, what is it? It is yeah, so he's right. French is basically the unit for measuring the catheter diameters, and this stands for the outer diameter. Okay, so French is an indicator of the outer diameter of the catheter, and it is equal to 0.03 centimeters or 0.33 millimeters. Okay, yes. So these 2 points you should remember, because see, nowadays they are asking a lot of things, and I have not put it up here, but you should remember the urinary catheter colors also. They are very, very important. Okay, so moving on to the next question: sequence of the hand washing. So what is the sequence of the hand washing? Simple. You have to first go for the palms, then you have to go to the dorsum of the hand, then you have to go for the fingers, and finally you have to go for the fingernails. Okay, so first is palm, then dorsum of the hand, fingers, and the fingernails. So this is exactly how you go for the washing. So this is palm, then you have to go for the dorsum, and then you have to rub the palm with the fingers, and then you have to go for the fingers, then the thumb, and finally the tips. That is fine. Now, important things which you may ask about this is, what is the ideal washing time? So it should be around 40 to 60 seconds. So this is the ideal washing time, and if you are using an alcohol based solution, you may reduce it down to 30 or 40 seconds. Okay, alcohol based solution to rub your hands, that is fine. So you may remember this. Right, so moving on, 10-year-old boy came to complain with right side scrotal swelling and everything for the 1 hour. So it is all indicated towards the testicular torsion. What is the management of the patient? So answer to this particular question is immediate exploration with contralateral orchidopexy. Okay, so it is immediate exploration with bilateral orchidopexy. That is the answer to this particular question. I really fail to understand how you guys did it wrong. Some of you might have did it wrong. So understand why, what is happening in here. So testicular torsion, this is a very, very important topic. So I have decided I'll cover it in detail today. So what is a testicular torsion? It's very simple. The testis is twisting on its own axis. That is what you call as a testicular torsion. What are the predisposing factors for this? You have a Bell-Clapper's anomaly, and then you have an inversion of testes. So what is the Bell-Clapper's anomaly? So it is basically high investment of the tunica vaginalis. So this is the normal testes. Okay, so this is your testes, this is your tunica vaginalis. It starts from here, it ends over here. This orange color structure is the epididymis. So this is the normal anatomy. Now what can happen? Rather than lying vertical, the testes may become horizontal. This is what is called as an inversion of testes. And then what can happen? This tunica vaginalis, rather than attaching to the lower end of the epididymis, it may continue and go till here, and this is what is called as a high investment of a tunica vaginalis. This is also referred to as the Bell-Clapper's anomaly. So what is Bell-Clapper's anomaly? So this acts like a bell, and this acts like a clapper. So what is a clapper? This is something which you see in the temples. So temples, you have a clapper like this, and inside this you have a bell. So this is something like this. Okay, so both these things, now just imagine if a testes is like this rather than being the normal anatomy, it has a more chance of undergoing a torsion rotation, right? So it is more chance of twisting on itself. So this is about testicular torsion. Now, how will the patient come to you? If at all the patient is suffering from a testicular torsion, how will he come to you? So the main complaint of the patient will be acute painful scrotal swelling. So this is the actual complaint of the patient. Then Whenever the patient comes to you with acute painful scrotal swelling, what are the differential diagnoses of the patient? So the differential diagnosis is testicular torsion, epididymoorchitis, and torsion of hydrated of Morgagni. What is this torsion of hydrated of Morgagni? We have testes over here, and over the top we have this remnant of the embryology, that is basically hydrated of Morgagni. Now you can see this is a pedunculated structure, so yes, very easily it can rotate on itself. If it rotates on itself, what will happen? The blood supply to this will get reduced, and over a period of time it will undergo ischemia and the necrosis. So this is something what you need to remember. In the torsion of hydrated of Morgagni, what do you get? You get a blue dot sign. So what is this blue dot sign? As I told you, because of the twisting force, it is undergoing the ischemia and the necrosis. So obviously it will turn out to be blue. And what is the rest of the skin? It is yellow in color. So if you just stretch the skin over the testes, what you will see? You will see a blue dot through the overlying normal skin. And that is why it is called as a blue dot sign. So this is a characteristic of torsion of hydrated of Morgagni. How do you manage these patients? You have to go for a conservative management. In other words, you just have to give them NSAIDs and painkillers and all those things, and the body will take care of whatever the remnant it is. Okay. Now another thing is, this is about the torsion. That is fine. Torsion of hydrated of Morgagni. What are the two conditions which are remaining? We have a testicular torsion and we have a epididymoorchitis. So how do you distinguish between these two? Okay. So in order to distinguish between these two, I'm really sorry, just a minute. Right. So in order to distinguish between these two, we have something which is called as a French sign. So what is this French sign? What you do in this, you elevate the testes. So if you elevate the testes and the pain of the patient reduces, then what is your diagnosis? It is epididymoorchitis. But if you elevate the testes and there is increase in the pain of the patient, so it is called as a testicular torsion. So this is how you can distinguish clinically. But this is very specific? No, not really. So what you have a supplementary test which is called as a Doppler. What is Doppler? You all know what is a Doppler. It is a test in which tells us about the blood flow. So what will happen in the testicular torsion? Will the blood flow increase or decrease? No rocket science in this. The testes are twisting on itself, so the blood flow to the testes will reduce. So there is reduction in the blood flow on the testicular torsion. Right. And what about this? In the epididymoorchitis, this is an infective or an inflammatory condition. So this will present to you with, I'm really sorry, I don't know why right. So here what will happen? Just a minute, guys. So in the epididymoorchitis, what will happen? There will be increase in the blood flow. Okay, so here there will be increase in the blood flow rather than reduction in the blood flow. Oh, yeah. So right. So in the epididymoorchitis, what will we have? We will have the increase in the blood flow, right? Okay, that's fine. What if the Doppler is equivocal, or what if you are in the PHC where no radiologist is available, or maybe the Doppler facility is not available? What will you do? If at all it is equivocal, or what if you are at some place where the Doppler facility is not available? Will you shift the patient to a place where the Doppler facility is available? No, not really. You will have to go for immediate operation. You have to derotate the testes, and then you have to see whether the testes is viable or not. If the testes is viable, go for orchidopexy. If the testes is not viable, then what you go for? You go for orchidectomy. Okay, so if the testes is not viable, you go for orchidectomy. Simple, nothing great about it. So just remove the testes because it is not viable, that is fine. But in both the cases, what you need to perform, you need to fix the opposite testes. Why? Because the opposite testes will obviously be under the, must be having the same congenital anomaly which was over here. Maybe the Bell-Clapper's anomaly or the inversion of testes or something. So you have to save that testes. Maybe the next time patient will not be able to come to you in the early phase. So to prevent it from undergoing the torsion, you fix that already, right? So this is about the management of a testicular torsion. They ask you about the golden period. So 6 years is the golden period. If you operate the torsion of the testes within 6 years, you have the high chance of saving the viability of that particular testis. So this is about testicular torsion. Now moving on to a ninth question: which of the following step is done is not done in the severe upper GI bleeding. So understand one thing. So okay, so what is the answer to this particular question? We have the platelet transfusion. So let us have a look about the upper GI bleeding. So before we move on, can you tell me what is the most common cause of the upper GI bleed? Most common cause of upper GI bleed. Okay, I'll give you the options. Is it a peptic ulcer or is it a esophageal varices? Can anybody answer in the comment box? What is the answer? See, please understand, the most common cause of upper GI bleeding is peptic ulcer. Okay, it is peptic ulcer. So peptic ulcer, this is more common cause of upper GI bleed as compared to it is a more common cause of upper GI bleed as compared to the esophageal varices. No. Danish, varices is not the most common cause. That's why I asked you, because it's a very simple question and sometimes students do it wrong. So this was the question which was asked in my particular thing also. No, Sampath, you already know this. So answer to this particular question is obviously peptic ulcer. So please understand peptic ulcer. My laptop is behaving a bit weird. I'm really sorry for that, but yeah, I'm continue. So peptic ulcer is the most common cause of upper GI bleed. Understand this. Peptic ulcer is more common as compared to the esophageal varices. Now what happens is esophageal varices, this sounds very, very attractive. So students tend to mark this, right? So this was the question which was asked when I attempted my NEET, right? So it's a very simple question, but please don't get confused in this, okay? So peptic ulcer is the most important cause of upper GI bleed. Most common cause of upper GI bleed. Now, because in the options they have given octreotide and all those things, so they are basically referring towards the esophageal varices. So management of the upper GI bleed in case of a peptic ulcer is a bit different, and the management of the upper GI bleed in esophageal varices, it is a bit different. Now, you will ask me, how will we know before we actually investigate the patient? So history will definitely help you. So if the patient is giving the history of a chronic NSAID use or something like that, go for the management of the upper GI bleed, considering that it is a peptic ulcer. But let's say if the patient has a cirrhosis, chronic alcoholic, having a lot of ascites, and now coming to you with the upper GI bleed. So what is the most common cause of esophageal varices? It is basically portal hypertension, which the primary cause of which is the cirrhosis of the liver. So yes, the history will definitely guide you towards that. Today what we are going to discuss, we are going to have a look about whenever there is a suspected variceal bleeding. So what you go for is, so whenever you have a variceal bleeding, patient will be coming to you in a hypodynamic state or hemodynamically instability or something. So obviously you will have to go for a IV cannula insertion and you will start the fluid resuscitation as soon as possible. Then what you will do, you will start the patient on IV octreotide, okay, and you may go for a telepressin. But understand, there is another drug which is called as a vasopressin. So will you go for this? Is this advisable to go for vasopressin? What are your views on this? So please understand, vasopressin can be given. Obviously it is a more potent vasoconstrictor, but sometimes what happens, it is such a potent vasoconstrictor that it reduces the intestinal blood supply. So it is not given usually. What is preferred is IV octreotide, okay? So IV octreotide is the one which is preferred. Then you will start the patient on antibiotics, that is fine, and then you will go for an endoscopic therapy. So what endoscopic intervention are you looking for here? So what you're trying to look for, so you're trying to undergo endoscopically, you have to go for right, so you have to go for band ligation. I'm really sorry, my pen is acting really weird. So we can go for a band ligation, or we can go for sclerotherapy. Which is the preferred one? So band ligation is the one which is preferred, okay? So I'll just talk because it is acting a bit weird sometimes. So what we'll prefer is band ligation. So this is important, okay? So rebleeding rates and whatever the patient complications and everything, they are better with band ligation as compared to the sclerotherapy. That is fine. If the patient's bleeding is under control, good enough, shift the patient to ICU and everything, and then you can start the patient on secondary prophylaxis. I'll talk about secondary prophylaxis in a while, don't worry. Then if the patient's bleeding is not getting controlled, or if at all the patient is suffering from recurrent hemorrhage, what you will do, you will again repeat the endoscopy. So how many times will you repeat the endoscopy? You will give 2 trials. If after 2 trials of endoscopy still you are not able to control the bleeding, then what you will go for is, you will have to go for consider balloon tamponade. So what is a balloon tamponade? You have a zinc-taken Blackmore tube, which is a triple lumen tube. It has one gastric balloon, one esophageal balloon, and it has one channel to aspirate the gastric contents. So remember, in the original zinc-taken Blackmore tube, you had only 3 channels. It was modified and then it was converted into a Minnesota's tube, which has a 4 channel. So zinc-taken, we have a gastric balloon, esophageal balloon, and a gastric aspiration port. What was added in the 4th channel? Esophageal aspiration port. how much amount of fluid which you air do you put in the gastric balloon? You first put 50 ml, then you put it like you pull it up, and then you put another 250 ml of the air. Okay, so this is how you go for a balloon inflation in the Sink stick in Blackmore tube. What about the esophagus? You have to maintain the pressure in the esophagus. The pressure should not exceed 40 millimeter of Hg. It should be less than 40 millimeter of Hg to control the bleeding. That is fine. If balloon tamponade is able to control the bead, good enough. If it is not able to control the bead, then you go for a transjugular intrahepatic portosystemic shunt. And if at all TIPS also fails, then you can go for a shunt surgery. Now, this discussion about all these things is beyond the scope of this video, but yes, this is how the management protocol of the varicose hemorrhage occurs. Okay, so I'll repeat: go for fluid resuscitation, go for antibiotic therapy, go for endoscopic therapy. You go for band ligation is the preferred one. If you're able to control the hemorrhage, good enough. Not able to control, and if there is a recurrent hemorrhage, you go for again endoscopic therapy. 2 attempts, failure, you go for balloon tamponade. If again failure, you go for TIPS. If TIPS is also not able to help you, you go for a shunt surgery, right? So this is about the management of the varicose hemorrhages. Now, what about the secondary prophylaxis? What do you start the patient on secondary prophylaxis? So you start the patient on beta blockers. So please understand, the old MCQ which they used to ask is the same MCQ. Instead of platelet transfusion, they used to give beta blockers. So beta blockers is not used in the active bleed. It is basically used for prophylaxis to prevent the rebleed. Another thing, now what they say that single use of the beta blockers is not good enough. So nowadays what they do, they club it with something. So they have said banding along with beta blockers, that is the best way to go forward, even for the prophylaxis. And you can also use TIPS surgery even to prevent the rebleed. Okay, so these are the details of management. That is okay. This is the basic management protocol of varicose hemorrhages. Okay, now moving on to the next question. Arrange the renal injury according to the severity. So this is actually arranged in the severity 1, 2, 3, 4. So let us have a look at the renal injury. Now this is basically from your Levin-Bailey, but remember something, in 2011 the new guidelines have come and it has been changed. But this is something which is given in your Levin-Bailey, so yes, we will stick to it. So not much of a changes, it is just that shattered kidney has been moved from 5 to 4. This is the only difference which has happened. Okay, so but we as this is given in Levin-Bailey, so we will stick to it. So what is happening over here? In the grade 1, there is just a contusion and a non-enlarging subcapsular perihematoma. So basically contusion with a non-enlarging hematoma. What is in grade 2? You have a superficial laceration of less than 1 centimeters depth, does not involve any collecting system. So you can go through that. That's fine. I'm just reading it. I'll show you the image and you will get the hang of it. So simple. In first, there is a non-expanding hematoma. 2, there is a laceration. It is less than 1 centimeters. Third, there is a laceration which is more than 1 centimeters, but still it like into the renal pelvis and the collecting system, no extravasation of the urine. Okay, so there is no extension to the like collecting system, and there is no extravasation of urine. So extravasation of urine, if at all it occurs, it is a grade 4. Okay, so in the grade 4, what happens? It is a bit detailed. So the laceration which extends into the renal pelvis, and there is a urine extravasation. So this is a buzzword. So urine extravasation, it starts from grade 4. Vascular injury, if there is an injury to the main renal artery or something, it is grade 4. Then segmental infarction without associated laceration and expanding. So what does it signify? It signifies the vessel injury. So without laceration, if the segment of the kidney is getting infarcted, this indicates that there must be some or the other vascular injury inside it. And if there is an expanding subcapsular hematoma, so this is something which is alarming to us. Expanding subcapsular hematoma. In the first, what do we have? We had non-enlarging or a non-expanding hematoma. In the grade 5, what do we have? We have a shattered kidney. We have avulsion of the renal hilum and everything. So this is fine. This is important. Uropelvic avulsion. So this is an absolute indication of surgery, right? So these are the grade 1 to grade 5. I've just tried to read this. This is a screenshot from your Levin-Bailey. So this is the diagram which has been shown. So this is subcapsular hematoma, non-expanding. So this is laceration less than 1 centimeters. This is laceration which is more than 1 centimeters. Then what is here? Pelvic calyceal system is getting involved. So that is why there is extravasation of urine. And if at all there is an expanding subcapsular hematoma, that is also grade 4. And here there is a grade 5 injury and avulsion of the pelvic calyceal system, uretero-pelvic junction avulsion, all those things. Okay, so this is grade 5. Okay, so this was not important till now, but now they have been asking these grades. So yeah, we have to remember the grades, right? Now, 2 of the things which you need in here, What is the investigation of choice if at all the patient is stable? So you can go for CECT. Now another thing which has been given in your Lovenberry also, what is the indication of performing a CT scan in a patient with a renal trauma? You don't perform a CT scan in every stable patient who is suffering from a renal trauma. So what is the indication? First, if the patient has a gross hematuria. Okay, so if the patient has a gross hematuria, you will go ahead and perform a CT scan. Next, if the patient is hemodynamically unstable, hemodynamic instability. So if the patient is hemodynamically unstable, then if the patient has microscopic hematuria, please understand this point, microscopic hematuria with instability, right? So you will have to perform a CT scan. So microscopic hematuria with hemodynamic instability, then you will have to perform a CT scan. Okay, so just a minute. Okay, so microscopic hematuria with hemodynamic instability. I'll not write it because my pen is acting a bit weird. I'll just enumerate. So gross hematuria, hemodynamic instability per se. Another thing is important. Just the microscopic hematuria is not an indication of performing a CT scan. Microscopic hematuria along with hemodynamic instability, that is the indication. Or any even and the fourth point is microscopic hematuria in children. So if at all there is a microscopic hematuria in children, the children don't need to be hemodynamically unstable. If you have a microscopic hematuria in children, it is an indication of performing a CT scan. So this is the difference. In adults, you need microscopic hematuria with hemodynamic instability. In children, you just need the microscopic hematuria to perform a CT scan. Okay, so this is about it. Now somebody was asking me fast. So right, so and he retracted it, that is fine. But see, fast is done as a first investigation. So if at all the patient is hemodynamically unstable and let's say the blunt trauma was the one which was leading to that instability, you will perform a fast. Okay, now what is the chance of getting a renal injury if you have a blunt trauma? Only 10%. So severe renal injuries occur only in 10% after the blunt trauma. 70% of the times there is a penetrating trauma which is leading to some severe injury in the renal. Are you understanding this point? So right. So penetrating trauma, if the patient was hemodynamically unstable, you will not perform a CT scan. You will directly go and rush to the OT. But if the patient is hemodynamically stable, you perform a CT urography to look for this. Okay, so now you'll have to read this particular topic in detail. I have covered the classification still and what is the indication of performing a CT scan. Another thing is, right, so what is the complication of massive blood transfusion? So understand this thing. The answer to this particular question is metabolic alkalosis. Now metabolic acidosis can also occur after a blood transfusion. So let us understand what is the confusion. So what is happening over here is, see, just read this statement and you will understand this. So each unit of RBCs contain 1 to 2 moles of acid. That is fine. This is generated why? Because of citric acid of the anticoagulant and from the lactic acid produced during the storage. So when this blood is stored inside the blood bank, there is accumulation of bit of acid over there because of a lactic acidosis which occurs because of the anaerobic respiration. That is all fine. But what happens? The citrate, when you have a massive blood transfusion, what happens? If you have a massive blood, okay, what do you mean by massive blood transfusion? Replacing the entire volume within 24 hours or replacing more than 50% of the volume within 3 to 4 hours. So this is what you understand by the massive blood transfusion. So obviously along with the blood, the anticoagulant will also enter the body. So what is the anticoagulant which we use to store the blood? It is CPDA, which is citrate. So what happens? Citrate goes inside the body and it goes hepatic metabolism to the bicarbonate. And during this massive, this is the reason why the patient lands up into metabolic alkalosis after a massive blood transfusion. Are you understanding my point? Are you understanding? So the acidosis can also occur, but this usually occurs after a couple of unit transfusion. And why this? Because acid component was accumulated when the blood was stored in the blood bank. When it enters into the body, it gets rapidly metabolized and it occurs a balance over it. But if at all you go for a massive blood transfusion, the citrate which is going along with the massive blood, it is getting metabolized in the liver and it is getting converted into bicarbonate, and this is responsible for the metabolic alkalosis. So that is why answer to this particular question is metabolic alkalosis. Are you understanding? Right. Another thing is, if at all the patient enters into hypothermia, After this, if you have transfused a very cold blood or something like that, then what will happen? This metabolism of citrate to the bicarbonate will be reduced or halted, and even the metabolism of the acid component which was stored in the blood, it will be reduced. So just one point, hypothermia increases the risk of metabolic acidosis after a blood transfusion. This is an independent statement. It has nothing to do with this, but it was somehow related to this particular concept. That is why I'm bringing up here. So two things: why metabolic alkalosis over here? Excess citrate which is going inside the body is getting converted into bicarbonate in the liver, which is responsible for the metabolic alkalosis. Completely different scenario if at all the patient is in the hypothermia, and if the patient is receiving a blood transfusion, he has a higher risk of landing up into metabolic acidosis. The reason is hypothermia will reduce the enzymatic activity, and you know the rest. Okay, so this is the particular question, right? Then which of the following is preserved in the radical neck dissection? So what is the answer to this particular question? So in the radical neck dissection, you preserve the digastric muscle. A very, very simple question. Now understand, I assume a couple of you watching this might have done this wrong, but since the day you started your preparation, you must have been hearing, neck dissection, very, very important topic. Many questions are asked on this. So in fact, it is a very important topic. So I've just made 2 slides for you. If you just go through them, everything will be cleared. So radical neck dissection, when did it come? It was introduced by Criley in 1906. What he did was, he removed lymph node stations 1 to 5. What are these? Submental, submandibular, upper middle, lower jugular, posterior triangle lymph nodes. So these 5 lymph node stations he removed. Along with this, which salivary gland did he remove? He removed the submandibular salivary gland. Along with this, he removed the spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. And this constituted the radical neck dissection. Even when Criley was alive, he thought over himself, and he said that if at all the spinal accessory nerve, internal jugular vein, and sternocleidomastoid are not involved, you may not remove it. Even he started saying that, and it is present in his literature. But what happened? After a period of time, the modified radical neck dissection was introduced by Boca, and he said that you don't need to remove it. So depending on which structure is preserved, we have different types of modified radical neck dissection. So he also removed the lymph node stations 1 to 5. He also removed the submandibular salivary gland. But what did he preserve? He preserved one or more of these structures. So if he preserved just the spinal accessory nerve, he called it as a type 1 modified radical neck dissection. If he preserved spinal accessory nerve along with the internal jugular vein, he called it as a type 2 modified radical neck dissection. And if he preserved all the 3 structures, that is spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle, then he labeled it as a type 3 modified radical neck dissection. Now another thing is, this type 3 modified radical neck dissection, this is also referred to as a functional neck dissection. So this is something which may be asked to you. In functional neck dissection, what do you preserve? You preserve all the 3. Okay, so just go through these slides, and yeah, this is an important topic. Then what do we have? Identify the drains. Now understand, this is not I won't say a completely out of the syllabus, but yes, it is not commonly used nowadays. So what is the drain which is used? So what is this drain? This is basically a Jackson-Pratt drain. Okay, so yeah, that's fine. Now you all must be knowing this. Now let us take a chance of having a look at the couple of images which may be asked to you. So what is this? The first one, this is a corrugated drain. What is this? This is a corrugated drain. Where do you use it? Let's say if you have an abscess, or sometimes it is also used in the breast abscess management. So what is happening in here? It is corrugated. Why it is called corrugated? Because it is in a zigzag pattern. So if you just put it into the subcutaneous tissue, what will happen? So whatever the pus may be collected, it may be drained along this corrugations, and the pus will be drained out, and the process of healing will be improved. Now understand one thing, this corrugated drain is a type of a open drain. Okay, so it is a type of a open drain. So it has the chances of infection. Why? Because yes, no doubt the pus is coming from the wound outside, but at the same time you have normal commensals over the skin, right? Staphylococcus epidermidis and all. So even the infection can go through this drain inside the wound, and that is why you don't keep it for more than 24 to 36 hours. You remove it after 1 to 2 days, because it is an open drain. Okay, so this is important. Then what is this? This is a Malacot catheter. Why it is called as a Malacot catheter? Because of this particular thing. So this is a self-retaining Malacot catheter. So just have a think about it. Where do you use it? If at all you want to go for an abscess drainage or something like that, you use this Malacot catheter. It can be used at various places, but one of the common uses is, let's say, a liver abscess drainage or something like that. Okay. Then what is this? This is important. So what is this? This is it is called as a Romovac. What it is called as it is called as a Romovac. So it is called as a Just a minute, guys. So it is called as a Romovac. Okay, so it is called as a Romovac. Now, what is this? Where do you use it? You use it in a patient's after breast carcinoma surgery. Okay, so you use it after the breast carcinoma surgery. It has two things. One is a flap drain, one is the axillary drain. So you put it one in the flap, one in the axilla, and you compress it, and whatever the seroma, which is the most common complication after modified radical mastectomy, it gets drained into this particular thing. If the output is less than 50 ml or so, you may plan to remove this drain. Now, what is this? Is it the younger brother of Romovac? What is it called as? It is called as a Minivac. Okay, right. So what is this? This is a Minivac. Okay, so this is a Minivac. So where do you use it? You use it for the similar purpose. Let's say after the thyroid surgery, you can put this over here. What is the reason? Why are you putting it? Are you putting it to prevent, drain whatever the seroma or something like that? No, you are basically trying to see whether it is a tension hematoma or any hemostasis is occurring nicely or not, or something like that. So you put this Minivac after the thyroid surgeries sometimes. Okay, you can use it anywhere. For example, if there is a very small cavity which needs a suction drainage, you can use this. So it is just a smaller version of Romovac. So if at all they ask you, not yet been asked, but if at all they ask you, please don't get confused. This is a Minivac and this is a Romovac, right? So these are the few things which I wanted you to know. Now, image-based question was asked on examination of a thyroid gland. So how do you examine a thyroid gland? So understand one thing, because see, you all must have read it in the final year, but I understand it. Tend to forget it. So there is something which is called as an inspection. Inspection, what you go for is the Pizzillo method. What is this Pizzillo method? You ask the patient to sit on a stool or something, put his or her both hands behind the neck and hyperextend the neck. What it happens, it makes the thyroid gland more prominent and it makes it easier to inspect. So this is basically for the inspection, not for the palpation. You ask the patient to deglutinate. If the mass is moving with the deglutination or something, you may diagnose it as a midline swelling or something like that. Okay, so by various methods, you examine, you inspect that particular swelling. What about this Pemberton sign? This is a very characteristic feature of a retrosternal goiter. So what is this? The patient is sitting in front of you, is absolutely fine. The minute you ask the patient to raise his both arms above his ears, what happens? There occurs a facial plethora. So his face becomes reddened. Why? Because retrosternal goiter is compressing on the vessels and is hampering the drainage of the blood from the face. So this is basically a Pemberton sign, which is a feature of a retrosternal goiter. Then what you have on the palpation, you have this Lahey's method and the Criley's method. So what is Lahey's method? You push the gland with one hand and you examine with the other hand. So if the gland is pushed to the one side and you examine with the other hand, you try to palpate the nodules, and you can also have a gentle palpation of the posterior lobe of this gland, that is called as a Lahey's gland. Okay, right. And what about this Criley's test? So in this, you use your thumb, you press the thyroid gland against the prominence, and you ask the patient to deglutinate. So this is a method to palpate the nodularity in the thyroid gland. Okay, so there's a bit of confusion what kind of video was shown, but just understand these particular things and you will be able to get to the answer. So Lahey's method is pushing the gland to the opposite side and palpating it. Most probably Lahey's is the thing which was shown, and the Criley's is basically pressing the gland along the prominence and asking the patient to deglutinate, so to look for the multinodularity of the thyroid gland. Okay, right. Then another video based question was asked on the thoracic outlet syndrome, and this is basically what was shown was Ross test. Okay, so it is what was shown was the Roos test. Now, what is a thoracic outlet syndrome? Just understand what happens in this. So what do we have? You have a thoracic outlet, and what is happening through the thoracic outlet? So all the vessels supplying the upper arms and the brachial plexus and the venous return and everything, this is happening from this thoracic outlet. Now, if at all, already the space is very narrow. If at all some other thing comes over here, what will happen? The space will become more narrower. And if it becomes more narrower, what will happen? It will compress whatever the structures are already present in this space. So what are the structures which are already present? You have an axillary artery, you have an axillary vein, and then you have a brachial plexus. So it can cause either as a neurogenic thoracic outlet syndrome, arterial thoracic outlet syndrome, or a venous thoracic outlet syndrome. If I ask you which is the most common one among these, so the most common is neurogenic. Okay, now why it can occur? So yes, one of the reasons why it can occur is, yes, Danish, you're right, it may occur because of a cervical rib. So yes, that is one of the causes, but that is not the only cause. It can occur due to any damn reason. For example, the anatomy of the first rib is malformed. If the ribs are supposed to be a flat structure, if they are not flat and they are globulous at the end, what will happen? It will compress on the surrounding structure. This is one thing. What else? What else can occur? If there is a fibrous band, extra fibrous band, which is connecting the ribs to the vertebra or something like that. So any reason can be there for this. Okay, but yes, cervical rib, that is the extra rib over the first rib. This is one of the common anatomical things which occur. Now, what did I tell you? It can be the neurogenic, arterial, or venous. So what are the signs and symptoms of the neurogenic thoracic outlet syndrome? This is important. And the most common one is the neurogenic. Please remember. So what will happen in the neurogenic? There will be altered sensations on the medial side of the arm running towards the, tip of the little finger. So this is on the medial side. So it is along the C8, T1 distribution. So all these things are important. This is also the distribution of the ulnar nerve. And what will you get? You will get the hypertrophy of thenar muscles or hypothenar. So please remember, you will get the hypertrophy of the hypothenar muscles. Thenar are along the thumb. So this is the hypothenar. So a distribution along C8T1 or along the distribution of the ulnar nerve, and you get the hypertrophy of the hypothenar muscles. So right, all these things indicate towards neurogenic thoracic outlet syndrome. Now, important thing is, how do you diagnose it? How do you diagnose this particular condition? So there is no any investigation of choice to diagnose it. So what do you have? You have something which is called as a provocative tests. So what do you understand by this provocative test? Provocative test means you provocate the symptoms out of it. The patient is not having the symptoms when he's sitting, but you perform some maneuvers and you provocate the disease to manifest the symptoms. Okay, so what you do in this, there are various methods to do it. So this was the session which I did on 15th of December. I'll talk about this. This was a part of our medical marathon, and we discussed all the tests. And on the screen you can see I'm demonstrating this Ross test or an East test. Okay, so let us have a look at what are the tests are there. So first is this AIIMS test. What is this AIIMS test? So in this, what you do, you ask the patient to extend the arm and you ask the patient to look at the opposite side. So very simple, you palpate the artery, and by performing this maneuver, if the pulsations of the artery reduces, this is the AIIMS test. Then what was asked to you in exam was a Ross test. It is also referred to as a East test. So what is this Ross test or an East test? This is an extended arm stress test. So what you do, you ask the patient to, elevate the arms and everything, and you ask the patient to go for opening and the closing of the particular thing. So after a period of time, the blood supply to the limbs will not be adequate and the patient will develop fatigue or something like that. So this is again a provocative test to diagnose the thoracic outlet syndrome. Now another thing is this Wright's hyperabduction test. So what do you do in this? You ask the patient to hyperabduct the arm above the ears or something, and if at all there is a reduction in the pulsations of the artery, this is diagnostic of thoracic outlet syndrome. The fourth one is going into the military position. It is also called as a Halstead's test. So you ask the patient to go to the military position, means the shoulder back, chest out and all those things, and the similar thing will occur. There will be reduction in the pulsations of the artery. So all these things will be able to diagnose that particular test. Okay, so just a minute guys. Right, so this is actually so this is the end of our today's session. We have covered 15 questions. So these were the pretty much asked. So it was a very balanced paper. I wouldn't say it was a very difficult paper. It was a balanced paper. Okay, I would say that. Yeah, a couple of questions were tricky, like for example, listening about the blood transfusion, you guys must have jumped over the metabolic acidosis and something like that. But yes, it was a bit balanced paper. Now after the paper, you all must have realized that at least 80% of the questions were from the topics which are very commonly asked. Okay, and the same happens with every paper, no matter what the exam is. Okay, so what I will suggest is you have like around 35-40 days to go for your NEET. So what you need to do is you need to revise only those topics which are very commonly asked, because if you commit a mistake in these topics, it's unpardonable. Okay, so this is what you call as the silly mistakes. Okay, so you missed it, you did a silly mistake or something like that. After every exam, you must be coming out and you must be saying that, I did at least 15 to 20 silly mistakes. If I wouldn't have done that, I would have got a really good rank. Must be happening, right? But what about toppers? Do toppers commit a silly mistake? Yes, they do. Okay, so yes, Right. I'll come back to Danish just a minute. So yes, toppers also commit a silly mistake. But what is happening over here is toppers commit only a couple of silly mistakes. Let's say 2 or 3. But if that number increases to 15, 20 or something, your ranks drops down to an average range. And if you like commit a silly mistakes to the tune of 30, 35, you're out of the competition. So this is what is happening with an student, like a normal student preparing for an exam. So what I will suggest at least now is in the coming days, just try to revise the topics what you have already read and try to revise 80% of the most commonly asked topics or common topics, important common topics. Don't try to read some ectopic things. Another thing is, so this was the session which I conducted. It was the first session of a medical marathon that was conducted on 15th of December. So I'll just take a minute and thank you so much for joining with me today. I hope today's session was at least a bit helpful for you. And I really appreciate you joining live with me today. Thank you so much, Danish, Shirish, Sampath, and everybody else who had joined with me. So what about this? If you're not following me on Unacademy, you can follow me on Unacademy. So you can get the updates about my free special classes and maybe the YouTube sessions. So you can just go on the link. It will be in the description box and you can go and follow me on Unacademy. I'll just take a couple of minutes of yours and I'll just explain you what we are doing on Unacademy platform. Now, I don't say this is the best thing ever and this is the thing which will help you to get a rank. Maybe not. But I just want to put a word out because this is something which not many people know, and we are trying to do few of the we are sweating. We're really putting up a lot of efforts in creating something for you on a Plus Academy which might help you. And just because of a lack of awareness, I don't think if somebody would have got benefited from it is not getting benefited. So just take up some time. I'll just take up some time and talk what about the Plus Academy. So what we are offering at present is there is a medical marathon which started on 15th of December. My sessions are already over. They were between 15th and 19th of December, right? And this session will continue from 15th of November till 15th of December. What will be happening in here? From 15th of November to 10th of December, all the educators will come and discuss their particular topics in a crisp and comprehensive manner. From the 11th to 15th, there will be daily discussion of around 500 MCQs live on the platform, and that will give you the MCQ practice. And myself, I have already launched this revision course in general surgery. It was launched today. I just took first session on the liver and portal hypertension. So what I'm doing in this, so if you are someone who has read general surgery very nicely, this might not benefit you. But if you are someone who is struggling with revision in the general surgery, this will definitely be of your help. So what I'm planning in here is, I have planned this course in 20 sessions and each session is of 2 hours. Okay, so what is being covered in here? So I will be covering hepatobiliary system in 3 sessions, GIT in let's say 4 sessions, general surgery in 6 sessions, Euro in 3 sessions, and I have kept one session which is dedicated to all the important classification systems in surgery, starting from the general surgery till the urology. Any important classification system I'll be covering in that. 2 sessions will be dedicated to all the image-based questions, and 1 session will be dedicated to the eponyms, all the triangles, NEEM surgeries and something like that. So if at all you feel that you can use this as a part of your revision strategy for general surgery, I'll be really happy to connect with you on this, but assess for yourself. I'm not saying come and join it, it is the ultimate thing, no. But if you feel that this might help you, you can definitely come and experience it. And in every session, I'll be discussing around 30 to 40 MCQs. So obviously it will also give you a hang of a MCQ. So I'm trying to develop this course in order to revise you. So if you just put in these 40 years, this will be helpful for you and you will be able to revise general surgery, right? So yes, thank you so much for listening to me and joining me on this. If at all you wish to join this, before 30th of November, we are offering the entire course in 999 rupees. What access will you have in 999? You will have access to all the medical marathon videos, you will have access to the MCQ sessions, and you will have access to the revision courses by me and any other faculty on that platform. The course is being offered at 999 rupees, 1 month subscription, if you use the promo code dr.pawan. Okay, so thank you so much for joining with me. I'll just take up a doubt of Danish. Danish is asking, so from 23rd November, you mentioned class, it's not showing. No, it has been already launched, Danish. It is being already launched. Just showed you a screenshot of that. Today morning I took my first session. Today morning 10 o'clock. So the sessions will be from 10 to 12 in the morning. Okay. So today I took my first session on liver and portal hypertension. So Danish, just go on my page and you will definitely find the course. Okay. So thank you so much for joining with me today. It was a pleasure connecting with you. I hope this was helpful to you in some way or the other. And yeah, if you're not, please follow me on Unacademy. I'll be really happy. And just stay calm. Don't get, back down because of the pressure of the exam. I understand it's a difficult period, but the worst scenario will be whatever you have read, you are not able to deliver it in the exam. So this is the worst scenario ever, okay? So if you read for these 40 days, I'm not saying that you will become like, you will come in the first 100 or something, maybe not. But at least you will be able to deliver what you have read, what you have worked for, what you deserve. If you don't work for these 40 days and you don't revise it in a strategic manner, what will happen? Whatever you have worked in the entire year, you will not be able to deliver it in the exam. And this is something very, very bad, okay? So this shouldn't happen. So please stay calm. I understand it is a difficult condition, but please stay calm, please stay focused and keep on revising the important topics. Thank you so much for joining with me. It was a pleasure connecting with you and hope to see you on the live classes on Unacademy in my revision session. It will be from 10 a.m. to 12 p.m. at 2-hour session starting at 10 a.m. 40 years, if you dedicate, I'm sure I'll be covering around 80-90% of all the important topics in the entire general surgery. You can check the date-wise schedule on the page if you just go there. Okay, so thank you so much for connecting with me. It was indeed a pleasure connecting with you. Have a nice day, guys. Bye.